So wound types. So we have intentional, which are usually surgical incisions, which are done in a controlled environment under a still procedure. Then we have non-intentional or traumatic, which occurred due to some type of trauma. And for these particular wounds, they were in an uncontrolled environment and they may require a tetanus shot or fluid administration or some type of intervention to prevent infection. Then we have our neuropathy or vascular wounds, and these are related to underlying neurological or circulatory issues. So for my group at Norton Square, some of you were able to see a vascular wound on one of our patients. Then we have pressure-related wounds. So pressure-related wounds are just that. They occur at bony prominence. Usually that's where these pressure ulcers occur because of the position of that particular bone resting on the chair, on the bed, or whatever the outside force that's causing the pressure is. And pressure ulcers are staged, which we learned about in lab. Later on, we'll review those stages again. And we also have acute and chronic. And I did skip over open and close. I'll come back. So acute wounds, such as surgical incisions, usually heal within days to weeks. The wound edges are well approximated. So that means that they meet and the skin surfaces close. And the risk for infection is low. Then we have our chronic wounds. Chronic wounds do not progress with normal sequence of repair or healing. The healing process is impeded. The wound edges are often non-approximated, and the risk for infection is increased. So it is a delay in the normal healing time, so more than 30 days to heal. So non-approximated, meaning that these wound edges do not come flush together. Then we have our open wounds and our closed wounds. The open wound occurs from intentional or unintentional trauma. The skin surface is broken, providing a portal of entry for microorganisms. Bleeding, tissue damage, and increased risk for infection occurs. It is delayed healing may occur as well. Okay, so this could either be an incision, such as a surgical incision, intentional, or it could be an abrasion, such as a traumatic wound, and unintentional. Then you have your closed wounds resulting from a blow, force, or strain caused by trauma, such as a fall or an assault or a motor vehicle crash. The skin surface is not broken, but the soft tissue is damaged and internal injury and hemorrhage may occur. So examples of this is ecchymosis and hematomas. So ecchymosis, you'll see bruising, scattered bruising on the skin. That's indicative of some internal bleeding occurring. And then hematoma is like a blood-filled blister. So it definitely is bleeding under the skin occurring. Question: which type of wound is caused by a blunt instrument that causes injury to underlying tissue with the underlying skin remaining intact? So we have arctusion, abrasion, laceration, avulsion. Correct. The answer is A, contusion. A contusion is caused by a blunt instrument and may result in bruising or hematoma. This wound terminology is found on page 1155, table 33-3. It explains each type of wound as well as the cause of the wound. So read through this and know this table, table 33-3, page 1155. On page 1156, box 33-1, it goes more in depth in reference to each of these bullets that's referring to the principles of wound healing. And it looks like there's 9 bullets. So intact skin is the first line of defense against microorganisms. Careful hand hygiene or hand washing is used when caring for a wound. So you want to cleanse your hands. Soap and water is always best, but you can use sanitizer. Cleanse your hands prior to wound care. After you take off the dirty dressing, change your gloves, wash your hands, then put on clean gloves before you touch the new clean dressing and apply that. Take off the gloves and wash your hands once more. The body responds systematically to trauma of any of its parts. An adequate blood supply is essential for normal body response to injury. Normal healing is promoted when the wound is free from foreign material. So the second slide for principles of wound healing. So the extent of damage and the person's state of health and wound healing. The response to wound is more effective if proper nutrition is maintained. And then these last 3 bullets are actually under maintaining nutrition. So malnourished patients are at a greater risk for developing wound infections. Then the next bullet talks about the role of fatty acids in wound healing. It's not well understood. However, certain quantities of glucose are necessary to meet the energy requirements for wound healing. And the last bullet talks about various vitamins, minerals, trace elements are also needed for wound healing. So vitamin A is necessary for collagen synthesis. Vitamin B complex serves as a cofactor of the enzyme reactions needed for wound healing. Vitamin C is needed for collagen synthesis, capillary formation, and resistance to infection. Vitamin K is needed for synthesis, and prothrombin and zinc, copper, and iron assist in collagen synthesis. Magnesium serves as a enzyme activator. Phases of wound healing include hemostasis, inflammatory, proliferation, maturation, and we'll talk about each of these stages later on. So there are 4 stages to wound healing. We'll discuss them in order. Hemostasis is the first stage, and hemostasis occurs immediately after there is injury. This phase causes the blood bleeding to stop by clot formation and platelet stimulation or activation. It also causes the white blood cells to come to that area and to fight any invading organisms. Okay, so exudate is formed as a result of that, and which causes swelling and pain. It also causes an increase in tissue perfusion, which results in warmth or heat and redness to that area. So the phases of wound healing actually are on page 1156 and it goes over into page 1157. So I wanted to say special attention to the hemostasis phase and special attention to the inflammatory phase as well. So inflammatory phase follows hemostasis and lasts about 2 to 3 days. White blood cells, primarily leukocytes and macrophage, move to the wound. That's important. You need to know that. White blood cells, leukocytes, and macrophage move to the wound in the inflammatory stage. Okay. Macrophages enter the wound area and remain for an extended period. They ingest debris and release growth factors that attract fibroblasts to fill in the wound. Exudate. Exudate is just a fancy word for drainage. It's formed and accumulates. It causes pain, redness, swelling at the site, same as our hemostasis phase, right? The patient has a generalized body response. Proliferation phase lasts for several weeks. Proliferation phase is also known as repair or fibroblastic, regenerative, or connective tissue phase, encompassing the process that results in actual healing. So new tissue is built to fill in the wound space through the action of fibroblasts. Capillaries grow across the wound. A thin layer of epithelial cells form across the wound. Granulation tissue forms a foundation for the scar tissue development. So you're actually starting the repair process in this proliferation phase. Maturation phase. The final stage of healing begins about 3 weeks after the injury, possibly continuing for months or years. Collagen is remodeling. New collagen is deposited, which compresses the blood cells in the wound, causing a scar. Scar can be flat, thin, a white line, a vascular collagen tissue that does not sweat, it does not sweat, does not grow hair or tan in the sunlight. So in this maturation phase, this is considered the final stages of healing, and it's also considered the stage of maturation or remodeling. And this is where our scar tissue starts to form. Question 3. In which phase of wound healing is new tissue built to fill the wound space primarily through the action of fibroblasts? A. Hemostasis. B. Inflammatory phase. C. Proliferation phase. D. Maturation phase. And the answer is C. Proliferation phase. In proliferation phase, granulation tissue is formed to fill the wound. All right, remember, always know the factors that affect our particular topic. So, local factors affecting wound healing begins on page 1157 and continues through page 1158. So, I will not read all these to you, but there's a paragraph on each, and I want you to read through them. Systemic factors affecting wound healing begins on page 1158 and goes into page 1159. So, age, children, and healthy adults heal more rapidly. Circulation, oxygenation, I want to call special attention to that. So, adequate blood flow is essential, okay, because the red blood cells carry oxygen on them, right? And oxygen helps promote healing. In addition, red blood cells also carry other nutrients that help promote healing as well. So, no oxygen, no life, no healing, right? On page 1158, it starts at the last paragraph towards the middle. It says circulation may be impaired in older adults and in people with peripheral vascular disease, cardiovascular disorders, hypertension, or diabetes. Oxygenation of tissue is decreased in people with anemia, and chronic respiratory disorders in those who smoke. So you want to call special attention to these circulatory disorders, particularly peripheral vascular disease, causing poor circulation in older adults, which will then affect their wound healing. So also nutritional status will affect the wound healing. So you have to have adequate nutrition, vitamins and supplements. Um, Wound etiology or the cause of the wound. Those conditions, if they're not resolved, they will affect wound healing. So if you have a pressure ulcer and this pressure is not being relieved, the wound will not heal. It will worsen. Health status, corticosteroid drugs and preoperative radiation therapy delays wound healing. So these drugs and procedures can impede immune response. Therefore, it could delay the wound healing as well. Immunosuppression. So because it's impeding the immune response, it is going to delay wound healing. Certain medications that are being used can delay wound healing. And adherence to treatment plan is a key factor in wound healing as well. If the wound is required to be changed daily or twice a day, that is changed timely, right? Wound complications begins on page 1160. Our first complication is infection, and wound infection results when a patient's immune system fails to control the growth of organisms in that particular wound. Then we have hemorrhage. Hemorrhage may occur from a slipped suture, dislodged clot at the wound site, infection, or the erosion of a blood vessel by a foreign body, such as a drain. So you always want to check the dressing and the wound under the dressing um, as frequently as possible in the first 24 hours of injury, especially if we have a surgical site. So in the surgical sites and other wounds, you should routinely check on them at least every 8 hours. And any additional pressure dressings that may be needed or packing that may be needed to reinforce the surgical dressing so that we do not develop complications related to that. It's laceration. They are most serious post-operative complications. Dehiscence is the partial or total separation of the wound layers as a result of excessive stress on the wound that's not healing. Evisceration is a more serious complication of dehiscence. It occurs primarily in abdominal incisions. In evisceration, abdominal wound completely separates and protrusion of viscera or internal organs. Remember I said visceral, think of organs. So viscera is internal organs through the incisional area. This places the patient at a great risk for infection. So what is the nurse going to do? So you have a wound at the his, okay? There is no organs protruding. It's just the wound edges have separated, okay? We're going to then apply a wet dressing on there, wet to dry dressing. So you take some sterile gauze and you will saturate them with normal saline, so 0.9 normal saline solution, right? And cover your dressing and then notify your healthcare provider. In the event that the dehiscence then has evisceration, which is abdominal um, organs start to come out of this incision, this is considered a medical emergency. You want to place the patient in a low Fowler's position to try to relieve the stress off of that area, that abdominal area. and you want to cover the exposed abdominal contents as discussed with a, a wet a dressing covered in saline, right, to keep the viscera moist. Then we also have our fistula formation. Fistula formation is abnormal passage from an internal organ or vessel to the outside of the body, or from one internal organ or vessel to another. We have a question. Which wound complication is caused by overhydration related to urinary or fecal incontinence? So we have necrosis, edema, desiccation, maceration. And the answer is D, maceration. Maceration is caused by overhydration related to incontinence that causes impaired skin integrity. Here is our picture of wound dehiscence and evisceration. So dehiscence is just the separation of those edges, showing us a partial. And then evisceration is when organs start to protrude out of that opening. And this is a serious complication of the dehiscence. Factors affecting pressure ulcer development begins on page 1162 and carries into page 1164. So aging skin, chronic illness, mobility, malnutrition, fecal and urinary incontinence, alteration of consciousness, spinal cord and brain injuries, neuromuscular disorders. These are all factors that can impact a person developing a pressure injury or pressure ulcer. On these pages, it goes more into detail about each of them, but these factors place them at a higher risk for developing ulcers. I do have highlighted box 33-3 on page 1163, the risk factors for pressure injury development. So I would suggest that you read through those. You should know those. And also, I want to bring your attention to box 33-2 on page 1160. It speaks about assessment of degree of wound infection, and it mnemonics here. Page 1162 and 63 talks about the mechanisms and pressure injury development. So external pressure injury occurs usually over bony prominence, where body weight is distributed over a small area without much subcutaneous fat or tissue, resulting in damaging of the skin. So this external pressure compresses the blood vessels, causing damage to the skin. Okay, compression of the blood vessels impedes circulation, impedes oxygenation, causes ischemia, okay, which is deficiency of blood in a particular area, or hypoxia, inadequate amount of oxygen available in the cells, and resulting in damage to the skin. Then we have our friction. Friction occurs when two surfaces rub together against each other. So friction or shearing forces tearing and injuring blood vessels. And then this causes direct injury to the skin, usually superficial. Then we have our microclimate. Microclimate refers to the temperature and moisture or humidity of the skin that comes into contact with the supporting surfaces such as bed or a device. So microclimate, temperature and moisture of the skin. So like a wet someone's the skin is damp or wet from incontinence, whether urine or feces, from wound drainage, that can also impair the skin. Risk for pressure injury development also includes nutrition and hydration, immobility, mental status, and age. And that continues on to page 1164. Okay, so we're going to go over our stages of pressure ulcers or pressure injury. So stage 1, this begins on page 1165 into 1167. So on 1165, it shows us a picture of healthy tissue for lighter colored skin and darker pigmentation. Okay, so you want to know what that looks like. Then you start with stage 1, and it shows us a picture of animated picture of the stage 1 as well as a real life picture. So familiarize yourself with the pictures. Okay, but stage 1 is non-blanchable erythema of intact skin. So the epidermis is intact, the outer layer of the skin is intact, and erythema just means it's red. Non-blanchable means when you press down on it, it does not turn white and return back to red. It remains red. Okay, so that is non-blanchable. It is considered a stage 1 wound. Okay, and in darker pigment skin, it may look slightly different. It may not be as red, right? Stage 2 wound is considered partial thickness skin loss and exposes the dermis, which is the next layer of skin underneath the epidermis. So this is a superficial opening, okay? So in the stage 2 wound, the wound bed is viable. It is pink or red. It's moist. And it could also be an intact serum filled blister. So serum just meaning like clear fluids, right? In that blister. Not blood filled blister, but a serum filled blister. Adipose fat is not visible. Okay, so it can be an intact blister or it can be a superficial opening for a stage 2. Don't want to confuse you. Granulation tissue, slough, eschar are not present in a stage 2. Then if we look at a stage 3, it is a full thickness skin loss, not involving underlying fascia. So for a stage 3 wound, adipose tissue is seen or visible. Okay, so we're going down to our subcutaneous level of the skin. And granulation tissue may be visible as well. Slough and eschar may be visible. The damage varies according to the location of the wound. Remember that these pressure injuries or pressure ulcers are caused by pressure on a bony prominence. Undermining and tunneling may occur. However, fascia, muscle, tendon, ligament, cartilage, and bone are not exposed. Stage 4, full thickness skin and tissue loss. So for stage 4, we have palpable, so you can touch the fascia, muscle, tendon, ligament, cartilage, or bone. You may also have slough and eschar visible. Undermining and tunneling may occur, and undermining and tunneling may occur in stage 3 as well. I'm not sure that I said that. But the biggest thing is for our stage 4, we will have bone, muscle, ligaments, tendons, fascia exposed. For unstaged wound, obscured full thickness skin and tissue loss. So full thickness skin and tissue loss in which the extent of the tissue damage within the ulcer cannot be confirmed because it is obscured by slough and eschar or eschar. So once the slough and the eschar is removed, it could possibly be a stage 3 or a stage 4. However, if the eschar is stable on the heel and or ischemic limb, it should not be softened or removed because it may become a chronic wound that never heals and may just be opening up a can of worms, right? At risk for nail infection and possibly amputation. We have our deep tissue pressure injury or DTI, deep tissue injury. Persistent non-blanchable red, maroon, or purple discoloration. So the skin could be either intact or non-intact. So you can have a wound that's open and it becomes a pressure injury. Or you can have skin that's intact and there is a pressure injury. So localized area with persistent non-blanchable deep red, maroon, or purple discoloration or epithelial separation revealing a dark wound bed or a blood-filled blister. So if it's a blood-filled blister, it is considered a DTI. However, if it's just a blister filled with serum or clear fluids, then it's considered a stage 2. So for our DTIs and for our unstaged wounds, we're unsure what stage this wound really is. We're unsure how deep the damage the tissue has occurred. And these wounds can open up to be a stage 3 or 4 once they're discovered.